everyone. My name is Benjamin Washira, emergency physician with the Emergency Medicine Foundation, and we're running this exciting series of triage this whole month. Last week you had AD triage, and today we're kicking off with pre-hospital triage. It's an exciting series. I mean, we're just preparing for the slides. For me, it was quite a journey. I do a lot of pre-hospital work. The academic aspects of pre-hospital care. So it was quite nice to see the advances of EMS pre-hospital triage. And I think most of us, maybe actually we could quickly check for the EMS participants who are here. Do you have triage protocols, documented triage protocols in your services? You can just put it in the chat. And remember, we will take questions in the Q&A part, and I will also answer questions through the chat. So feel free to put in your questions through there. Yes, so but the first question is, do you have printed pre-hospital triage protocols? I see Ahmed saying no. Is there anyone in a service that has clear triage protocols? A lot of no's coming in. All right, so which is good. And potentially one of the things that we'll end up doing as our foundation, we are starting to work on the pre-hospital aspects of our care. So good to see that there is a big gap in pre-hospital triage. All right, so good. Thank you, everyone. Hi, Sam. Welcome. All right, so thank you very much for those who responded. So we're going to discuss pre-hospital triage. There is very few countries actually have well-designed pre-hospital triage systems. It's a gap, I think, that has existed. But those that have the systems that exist, the tools that exist at the moment, quite impressive in terms of the rationality and how to use them. And down the line from this talk, it is for you and your service to develop your own triage tool as a service. And we'll share some of the resources that you can use to develop this, and just to give you an idea how it looks like in the pre-hospital setting. Down the line, of course, hopefully, we'll end up with national pre-hospital triage, but not many countries even have this. I think only Singapore I saw that have. I think there's some from the US, but I will discuss it. So what's the importance of having pre-hospital triage protocol? So I know the normal response has always been take the patient to the closest appropriate hospital. But with the complexity of the patients, especially as we move into different disease conditions, and where certain disease conditions have time limitations in terms of treatment, then it's no longer just take the patient to the nearest hospital or the closest hospital, or even, and now when you say closest appropriate hospital, there's even variations on that. So destinations of hospital choice may change also based on available resources. So you can, a patient needs a CT scan, but the hospital doesn't have a CT scan. Patient needs a cath lab, but there's no cath lab, for example. Or, for example, a severely injured patient being taken to a facility that may not have the surgeon readily available, take this patient to theater. And there's a good evidence out there that shows transporting, for example, severely injured patients to trauma centers as leads to better outcomes. Transporting stroke patients to stroke centers has better outcomes. Transporting heart attack patients to cardiac centers has better outcomes. So pre-hospital triage is tied a lot also to the development of hospitals and the capacity of hospitals, because there's that need to designate specific hospitals, specific services to improve patient outcomes. And remember that pre-hospital, you're the first people who always come across this patient. And it would be sad if all the pre-hospital work that is done or that you do pretty much dies when the patient gets to a hospital, which doesn't have the appropriate resources. So pre-hospital care is not just about moving patients from point A to point B. It's you can be rushing with a siren, go and give the best pre-hospital care, but then you transport your patient to a facility that doesn't have an emergency department or well-appropriate staff. So everything that you did equates to zero because the patient just dies on arrival at the hospital. And I think you've seen a lot of this. So, and that's why the two services need to go hand in hand. As we develop emergency departments, we need to develop pre-hospital systems, but also as we develop pre-hospital systems, we need to develop emergency departments. The two work hand in hand. They're not two separate things. So a lot of literature has recently shown that things like hospital emergency department overcrowding, lack of resources, of course, leads to poor outcomes for patients. Diversion of ambulances also has good evidence to lead to poor outcomes. So where an ambulance head to your emergency department and then they get to your door and you tell them, go to another hospital. Just that simple act increases your patient's mortality and leads to a lot of chaos. So the key question is then why? Why do we need to have pre-hospital triage systems? And there are very many reasons. And this is a whole list, number 1 to 6, looking at issues of resource allocation. Of course, by triaging, especially where you have a limited ambulance service, then by triaging, and that's the thing I'll also discuss, it's where does triaging start in the pre-hospital space? But triage categories, again, help you prioritize which ambulances. So there's prioritization of care, but there's also, if a patient has minor issues, you can send an ambulance, a BLS ambulance that's less equipped, versus a complicated patient, then you need to send more complicated resources. Also, pre-hospital triage helps you rapidly identify life-threatening conditions and intervene appropriately. And this is key in terms of patient survival. And then, of course, as I mentioned, the efficient use of transport resources. In a proper system, probably the amount of calls definitely exceed the available resources. So you have to use the transport resources. And some patients, especially in Western countries, for example, they realize that not all patients need a van, for example. And now that's where the motorcycle response vehicle, your the cars, ambulance cars. Actually, I think with time, we probably may end up seeing ambulance cars in this country, and someone should actually be thinking about it. The same size like your small vehicles, the Ubers that we see, but if with appropriate medical equipment at the back. Remember, the only benefit you have with the van is to transport the patient. But if the provider with all the equipment and resources available in the car can get to the patient faster than the van, then they can provide that stabilization. And then all you need a van for is to move the patient. And then other things about benefit of pre-hospital triage, looking at effective overall improvements of the system, patient flow, ensuring reduces treatment delays, patient flow, and communication and coordination, especially from a pre-hospital to the hospital perspective. When the pre-hospital has triaged the patient, I'll use the word red for now, but that varies. Then at hospital level, you should be able to understand that this is a red patient that needs. So harmonization also of pre-hospital and ED triage in many settings. I think I only know one place. I think the Canadian system, the Canadian triage sitters, Canadian triage and acuity system has harmonized pre-hospital and in-hospital. So that a red outside the hospital is a red in the hospital, a green outside the hospital is a green in inside the hospital. And just so that we clarify, today's talk is about normal routine ambulance care or pre-hospital care. This is not mass casualty triage. Mass casualty triage will be captured in the next series, the one after next week. So this is just about everyday patient triage in the pre-hospital setting. All right. This is a good article to read. You can take a snap of it on your phone, but this is, you can find it. Nick Coffey, I know Nick Coffey is that guy I've worked with on a lot of papers. He's Ghanaian American, has a lot of pre-hospital work. And a lot of what I'll be presenting today was pretty much captured in this. That was published in 2022. So it's a good place to start. All right. So just as a basic understanding, I think we all know that we have two ambulance service systems. There is the Anglo-American system and the Franco-German system. And in many settings, I think even in Kenya, we actually don't do the Franco-German, but some aspects are captured both ways. So if we're looking at the Anglo-American system, which is probably what we have more in our setting here, is a scoop and run or load and go. So where you go pick a patient and move, you either have EMTs, paramedics presenting, and mostly BLS ambulance, but in our setting now, we actually have ALS ambulances. And then usually the system is to bring the patient to the doctor, okay? And I like the last comment there, which is usually, yes, they're just transferring the problem to the nearest hospital. So they don't necessarily intervene in a pre-hospital setting, or sometimes minimal intervention, and then transfer the problem to the hospital. At the Anglo-American system, I think our system in Kenya is like that. I don't know many ambulance services locally that have a doctor on board. And let's look at the other part of it. And actually, one of the things that maybe we should also looking at is how do we create EMS personnel for the entire spectrum, pre-hospital, doctors and nurses, for example. But the other part of it, the Franco-German system, is the stay and play or stay and stabilize. Okay, and I've actually worked in both systems. When I was a doctor in both systems, but the other system is very interesting, the Franco-German system, because you go as a doctor, you have all the tools you need with the patient, and you're able to do a lot of stuff. And so you probably be on site for close to even half an hour just doing stuff with the patient. I'll get my 12V DCG, I'll set up IV access, start the fast medications. So it's physician to doctor, to patient, sorry. And the MICU is a mobile ICU, okay? And the helicopter emergency services. So that's normally what you'll be using. So rarely are you talking about, like even when you're responding with a vehicle, you're not responding with an ambulance. You're either responding with a MICU car, so it's a car that has a staff in it, and or it's a helicopter, that's so cool. But you pretty much have a lot of resources with you to provide the care that patient may require. At some points, even you thrombolize the patient out in the field. Patients are directly, in that system, the good thing is patients are transferred directly to the inpatient service. So you are moving a patient from the house, you stabilize them, done everything, they go straight to a hospital ward bed. They're not going through the emergency department. But as I mentioned, it's taking a lot of time on scene, and it is not cheap. So at some point, so I mean, in many countries, they probably are either Anglo-American or Franco-German, but in some, like in the South African system, there's a bit of a balance because for certain calls, the ambulance van was sent with a doctor in a car. Yes. So so it all depends. So it's a good balance because you don't need a doctor to go for every single call, but there are specific calls, and this is where the triage comes in. Where at triage at dispatch level, they decide whether a doctor will be required or not. And actually that is a good segue to my next. Oh yeah, when all fails, that just stay and pray. Okay. So if we look at it from the perspective of where does triage happen? So unlike the emergency department where just triage happens at the door when the patient is coming in, on a pre-hospital level, there are actually multiple levels of dispatch. And the first part, multiple levels of triage. And the first part where triage happens is at the dispatch level, okay? This is where the call taker has to decide very many things through that call, and I'll discuss that in detail a bit more. Is number one, how sick do you sound, or what symptoms are you presenting with? How far are you? And what resources do I have to send to you? So all that is triage, and they then have to prioritize based on just simply how far are you, what resources do I have, and how sick are you? Then I have to decide what resource I'll have to send to you. And then that's at dispatch level, and I'll go into details as we go along. And then there's a scene level. The scene level is when now you arrive at the scene of the patient, and then you have to triage this patient. And remember I said, this is not about mass casualty triage. This is where it's you and one patient, and you have to triage this patient because this will then make a determination on multiple aspects. So it's number one, how fast are we gonna do this? So are we gonna stay and play a bit, or are we just picking and going? And the next question is, of course, is where are we going? Yes. So is it, am I going to hospital A, B, C, or D? What's the best hospital for the patient, for this patient to receive the best outcome? Okay. And then, I mean, there's so many decisions you make at this point, and that's also is part of your triage process. So the pre-hospital triage scene is a bit way more complicated than an in-hospital setting. Because in in-hospital setting, I just receive patient, I'm triaging you and immediate resource. Oh, you're gonna have a wait and we'll see you later. But I don't have to think about transport or where am I taking you to. But it's very different in a pre-hospital setting. And that's why it's important for services to start looking at developing specific protocols, creating relationships with the hospitals that they serve, and have that understanding that sometimes I'll pick a patient here and I want to bring them to you because this patient is best served there. That whole, for example, in the public setting, the whole concept of take the patient first to the sub-county hospital, then from sub-county hospital to main hospital, that, as I said, the diversion issue creates a lot of inefficiencies and has been associated with increased patient mortality. So there is the need to us look at for the EMS service and the facilities to work together. So it's not that EMS creates their own system, that will just be chaos. So there needs to be a harmonization between the EMS service and the facilities that they serve to be able to create a harmonious, and this is not a referral system, just for the people confuse this with referral. And most places, ambulances are listed together with referral services. This is not referral, this is primary response. And this is very different, and there's a need for clear protocols as about ambulances responding for primary response. And then there's the AD level of triage, which we discussed last week. Yes, the recording will be available on Data Online or on our YouTube channel, probably in the next week or so. All right, so let's look at dispatch. So this is where I found a lot of chaos, okay, or confusion. Because there is the issue of prioritization of patients, and there's the issue of the code, what kind of ambulance response code you have. And there's no clear harmonization. Even in America, for example, there is different services. So the issue behind the prioritization is, for example, in perspective of priority 1 is dead on arrival or trauma or CPR, priority 2 is emergency, Priority 3 is non-emergency. Priority 4, situation under the control. Priority 5, casualty incident. That's when the person receives a call and is making decisions based on this information. So naturally, there needs to be some categorization as to what is an emergency, what's a non-emergency. And there's no clear evidence available at the moment. Say we should be using this specific criteria, or we should be using this. The issue of prioritization varies significantly, and it's not harmonized, and it's normally service dependent. So, and as you develop your protocols, then you need to tell us what the prioritization, and make sure everyone knows what the priorities are. Let's see, where are my slides? Wait. Oh, you can't see my slides here. Sorry, you can. Sorry about that. All right. And then there's a code part. So the code part mainly is about how the ambulance responds. Okay. So there is code 3, which is the confusing part for me, because I'm like, what do you mean? Code 3 is the emergency, but priority 1 is the emergency. So this is what I was saying, there's just confusion about this, and it has to be very specific based on the service. So I could not find any harmonization on this. Similarly, there's some use colors. So yeah, so as you can see, this is code 1, respond to call without emergency lights. Code 3 is response lights and sirens. So it varies significantly with different services. And so as at dispatch level, you'd have to create, you have to define what this will look like. And what are we going to categorize as priority 1, also going to categorize as priority 5. And as I said, you don't need to recreate this, it's already existing. So you need to pick one and adapt it and make it yours. Down the line, hopefully, we will be able, as a country, maybe have specific codes that are pre-designed or priorities that are pre-designed and that are universally used by all services. And that would be the objective, to make sure that there's harmonization. Okay, so that's as much as I can say around dispatch triage. There are no specific tools like what we'll discuss for the scene kind of triage. These are varied to different kind of tools that exist for the dispatch protocols that exist. There is no standard ones. All right, so let's look at what happens when you get on the scene. All right, I see there's a question. Audio is breaking, not clear. Okay, as maybe an internet issue. Hopefully that will sort itself out. So when you're looking at scene triage, now, interesting enough, when we're looking at all the available tools for triage, there are 3 levels of tools that have been developed largely for pre-hospital care. There are a lot of stroke triage tools, and stroke triage tools have evolved. So for those who are still at Cincinnati and Los Angeles, things have evolved since then. And we'll discuss that in the next couple of slides. So stroke triage tools essentially promote rapid identification of patients with acute large vessel occlusion ischemic stroke. So it's not the things that move beyond just identifying a patient having a stroke. I think we're all happy with fast. But now I need to identify a patient with a large vessel occlusion ischemic stroke. And that's where most of the tools have been developed around that. And again, same issue of time is brain. So that's where the tools have been developed. Other tools that have been developed largely are trauma triage tools. Okay. And again, usually to identify patients who need to be transported rapidly to a trauma center with emergency surgery capability. So it's not just taking a patient to any random hospital, but it's to a specific hospital with trauma triage capabilities. And then the 3rd level of tools is just the general triage tools. So essentially, these are the ones now that look at the patient holistically. They're not condition specific. So they look at vital signs, mental status, assessment, history exam, and resources and things like that. So those are the ones now more about all patients. Okay, so I'll just quickly review some of the existing tools for the different ones. And again, if you're looking to develop tools for your service, then you will potentially need to combine these 3 levels of tools. So you have general triage tools and then specific tools for stroke and specific tools for trauma, because these have been well studied and available. All right. So when you're looking at stroke pre-hospital triage tools, these are a very good paper also to go look at, the Presto trial or Presto study. So it was looking at actually 8 pre-hospital stroke scales to detect intracranial large vessel occlusion in suspected stroke patients. So yes, so it's not the 2 that you learn in ACLS. That has evolved significantly. So there are actually 8 different tools. And here's a list of the 8. I'm not going to go through each of these tools. It's them. But the ones I've highlighted in red are the ones that have currently good evidence and most been shown to be sensitive and specific for detecting acute. So ALVO is acute large vessel occlusion stroke. So there's a RACE tool, so rapid arterial occlusion evaluation, gaze, face, arm, speech, time tool, and then the conveniently grasped field assessment stroke triage tool. Yes. Just a quick distinction. For example, the Los Angeles Prehospital screening tool is a screening tool. It's not a categorization of patients tool. So the FAST, what you all know as FAST, is mainly just to quickly say, I think you have a stroke. But beyond that, as a pre-hospital healthcare provider, you need to go to this level of tools, the ones I'm highlighting now. So the first one is like, oh, FAST, you're having a stroke. The next question is, are you having an acute large vessel occlusion stroke? And we'll highlight just where this is coming from. So I'll just quickly show you the RACE, EMS RACE stroke scale, which ideally would be what you'd be adapting for your service. So essentially has 1, 2, 3, 4, 5. We have 5 different levels. So there's facial palsy, and there's clear instruction as the patient to show you their smile and teeth. So they're still the same stuff, but these ones are a bit more detailed. As you can see, you get a score for each of your responses there. So if it's absent, you get a 0 score. If it's moderate to severe, you get a 2 score. And then there's arm motor function. So it's the whole extend the arm 90 or 45 degrees. See, looking for the drift, there's the leg has been, okay, extend the leg of the patient 30 degrees is supine. Observe the eyes and head deviation to one side. And then I'll be able to talk. Okay, so if there's right hemiparesis, then you're asking them, ask the patient for the 2 verbal, close your eyes, make a face, and what response do they have for that? And then there's the nausea, ask what arm is this? While showing him or her there. Yeah, sorry, I can't remember the other arm. Yes, and then can you move your arms, for example? Okay. Oh yeah, so it's to use that one. Okay. All right. So again, so then each of these gets different scores, and this helps the severity of your stroke and the need for you to be transported to a stroke center. Okay. So the severity-based stroke triage algorithm for EMS. I'm just gonna change what I'm sharing. So you can see this is a severity-based stroke triage algorithm for EMS. And it starts on this side here, where the EMS dispatch notifies the protocol. So the appropriate EMS crew dispatched by the regional stroke protocol. And then on arrival, they do the ABC interventions, check sugar, and of course, the ABCs, and intervene if the patient is unstable. Then you're doing a quick screening tool. This is where your Los Angeles Prehospital Screening Tool comes in, and you're doing point of care blood glucose. And then if your screen is positive, so that's your fast, okay? And stroke is suspected, then yes. Then identify and document time last known well and time of symptom discovery. Then performance now is where your RACE tool comes in. Okay, so you have to do a RACE or any of the many others, but RACE has been well validated. And then is there a large vessel obstruction suspected? If yes, then last known, so this is LW's last known time well was less than 6 hours. If yes, now you transport them to, so there are different levels of stroke center, and people are moving away from to more thrombectomy. I think we do it at Aga Khan. I'm not sure who else still is doing thrombectomy in the country. But yeah, so it's something that is slowly coming to the country. And if direct transport to a comprehensive stroke center adds less than equal of 50 minutes less, then they bring the patient. Transport to comprehensive stroke center will not preclude use of alteplase. Yes, then they come. Yeah. If not, so there are different levels of stroke centers. So a lot of it then will determine. So there is primary stroke centers, thrombectomy stroke centers, comprehensive stroke centers. But bottom line is, if your patient has an acute large vessel obstruction, it started less than 6 hours ago, and they can get to comprehensive thrombectomy center as quickly as possible, then they potentially should be going there.
So that's the main one, and that's what you need to know for your stroke. So the RACE stroke scale is what is being used a lot by EMS to detect acute large vessel obstructions, large vessel occlusion, sorry. Yes. So the other part of it is a trauma pre-hospital triage tools. Now, again, as you can see, there are multiple tools that have been developed. There's a MGAP, so mechanism, GCS, age, SPP, and the GAP score. So these two scores essentially have been best validated in terms of pre-hospital triage tools. And remember, the issue about pre-hospital triage is to get the patient quickly to the most appropriate trauma center where they can get thrombolysis done. And that's the main objective. So the idea is to quickly triage a patient to a major trauma center and not just any emergency department or any hospital. Taking patients to hospitals that are not trauma centers or do not have the capacity to provide that trauma care has been shown to increase patient mortality. Yes, have been shown to increase patient mortality and cause a lot of unnecessary deaths. So taking patients, using these triage tools then helps you prioritize which patients should be taken to a trauma center, which patient can be managed in just a regular hospital.
All right, so if you're looking at the difference, so if you look at the MGAP, all right, so essentially the MGAP has the following variables. So there is the age, GCS, and then, go back. Systolic blood pressure, okay? And the difference between MGAP and GAP is the GAP doesn't use the GCS that's not used, sorry. There we go. All right, so low risk group, so a score of 23 to 29 for MGAP. Mechanism of trauma is not used for the GAP score. Sorry about that. Yes, so in low risk group, 2029, the MGAP on is 25 for the GAP. Moderate risk group is 18 to 22 score, similar, and you can see the mortality is. Okay, so if a patient, for example, has a low risk category, then they don't necessarily need to go to a trauma center, for example. But a patient with a moderate risk group, you can see the mortality rate is quite significant, it's 15%. And your high risk group, as you can see, they almost have a 50% mortality rate. And so you need to be able to quickly identify these patients and take them. And this is where now discussions, for example, about should in a Kenyan setting, should patients go straight to Kenyatta Hospital? This is one of the discussions that needs to be had, because for patients with an almost 50% mortality rate, then they need to go to probably the highest level hospital to get the care. That's the importance of the triage system. But again, as I mentioned, we need to develop the triage system in conjunction with the facilities so that we are all having the same discussion. So when you're transporting a patient and you say their end gap is less than 11, there should be no discussion about which hospital this patient should be going to. And that's the beauty of triage. I mentioned it improves communication and also allows appropriate resource allocation. All right. The other one that has been studied is the triage device trauma score. Okay, and essentially ranges from 0 to 12. What you see here is essentially it looks at 3 different components: the respiratory rate, circulation, and conscious levels, which is DCS. And so this uses a score of maximum score of 4. And that's again, the lower your score on this, then the more reason you should be going to triage, to a trauma center. And they've actually looked at what are the appropriate cutoffs, and they vary. Yeah, you can read on this and see how that works. But the main idea behind this is to make sure that the appropriate trauma patient gets to the appropriate trauma facility. Now, for those who do ATLS and PHTLS, you may have come across this. This is from the American College of Surgeons, the National Guideline for Field Triage of Injured Patients 2021 guide that essentially was developed the American College of Surgeons and is now being used in different areas. And essentially it has 2 main areas. It's either red criteria or yellow criteria. And you can see, so it looks at injury patterns and mental status and mental signs. So injury patterns become a significant thing. Mechanism of injury, like the other one, the M-gap also. So patients with penetrating injuries to the head, neck, torso, proximal extremities, skull deformity, suspended skull fracture, spinal cord injury with neurology, chest wall instability, deformity, suspended failed chest, pelvic fractures. So this is where, again, it's not just a matter of picking a patient from an accident scene and just rushing them to the hospital. You need to be able to do some level of assessment to make sure that you're transporting your patient to the appropriate hospital. Like I said, it's not every hospital that has the capabilities to manage major trauma. And you taking a patient to a hospital that has no capacity to manage major trauma increases that patient's mortality. Yes, you just taking that patient there and it's the wrong hospital, automatically increases that patient's mortality. So, and that's why there's these triage tools to ensure that the right patient goes to the right hospital to reduce on their mortality. As you can see, things like active bleeding, going at tourniquet, amputation, and the rest. And when you look at the mental status and vital signs, you can see this level of consciousness, respiratory rate, respiratory distress or need for respiratory support. Age is a factor. And also things like the blood pressures, the systolic blood pressure. In trauma, systolic blood pressure is a significant thing in terms of how quickly patient is bleeding and perfusion. Right? So that's the red criteria, but it also has yellow criteria. So again, same perspective, looking at mechanism of injury. So high risk auto crash with partial or complete ejection, sigmoid protrusion. So the difference here is, and I'll just highlight that, if you see at the bottom there, any patient with red criteria should go to the highest level at trauma center available. So if you're at a county level, you're talking about a county referral hospital. If you're within Nairobi, maybe national referral hospital kind of thing. But if you have yellow criteria, then you may be able to be taken to what we call a regional trauma center, which could be a sub-county hospital. You don't always need to go to the major hospital. But still, even in that sub-county hospital, there needs to be the resources to manage trauma. And there needs to be the personnel to manage trauma. So it's not just saying stick in the hospital and expecting someone will sort them out. No, but there should be a clear criteria. So as you can see, this is again significant intrusion, death in passenger compartment, unrestrained child, pedestrian, bicycle rider thrown or run over with a significant impact, fall from height, more than 10 feet, all ages. And then also there's the EMS assessment. So this is again, you as a EMS provider need to make an assessment and consider some of these risk factors. Pregnancy more than 20 weeks, burns in conjunction with trauma, special high resource healthcare needs, and anticoagulant use, and similar that needs to be assessed. So again, if you're concerned, take to a trauma center. So if you're not red criteria, you're not yellow criteria, then you probably can be managed in a regular hospital with nothing fancy, or at least maybe sutures and gauze and all that, but not necessarily needing a surgical intervention. Okay. And again, then, so it's not all trauma patients going to one hospital. Is you distributing the patients appropriately based on specific criteria that has been agreed upon. And that's why you need to have everyone understanding this criteria. Yes. All right. The last part of it is your general triage tools. Okay. And so this one's essentially holistic. They're not disease specific. So they're not just for stroke, for example, or trauma. It's just normal patient care. And like I mentioned, at least I want to highlight the Canadian one. So there's a Prehospital Canadian Trauma and Acuity Scale. Sorry, Canadian Prehospital and Acuity Scale. It's not trauma. But there's also in-hospital CITAS criteria. Yes, so Canadian AD Triage and Acuity Scale. So this is Prehospital Triage Acuity Scale. That's what the T is for. It's not trauma. And the good thing about this is it's harmonized between pre-hospital and in-hospital. So whatever information you gather from pre-hospital automatically translates into the hospital setting. So a criteria red in pre-hospital is red in hospital setting. So, but looking at the Philadelphia EMS admission rule, and again, this helps in terms of determining how sick the patient is. And as you can see here, it's a probability of hospital admission. So the higher your probability, the higher your score, the higher your probability of admission. And then you use this then to determine which hospital this patient. So a patient with low pre-hospital probability of admission, then probably they need to go to the biggest hospital, versus a patient with a high pre-hospital probability of admission, then they probably need to go to the better hospital or the most appropriate hospital. And essentially, as you can see, it looks at various EMS variables that have various, I'd say, sex odds, mortality, I guess. So if you look at also predicting hospital admission, odds. So the ones the highest patient with shortness of breath has the highest odds that this patient will need to be admitted in a hospital. And age above 60, patients complaining of chest pain, patients with a history of cancer, complaints of dizziness, weakness, or syncope, and then history of diabetes. So this specific criteria, as you can see that there's points that are awarded to it. So if a patient meets any of these specific criteria, then there's more likelihood that then they will need to be admitted in hospital, and that's taken to an appropriate hospital. So not taken just to any random hospital. Yes. All right. And then I will go into details with this one because it's very interestingly comprehensive. Okay. So it starts off with there's what we call CITAS rule. So it's a Prehospital Canadian Triage Acuity Scale. So the following rules must be considered by paramedics when assigning CITAS levels to patients. So rule number one is a minimum of 2 CITAS scores must be applied to each patient. So that means you have to do CITAS twice. And normally they will do it on scene on their arrival and then en route or on arrival at the hospital. They will do that. And then the CITAS level reported to the receiving institution is the level at departure from scene, or if the patient's condition deteriorates after transport has been initiated. So even when you're reporting this CITAS, you're telling us, even if you intervened, but what was their CITAS initially? But if it has also gone down, then we also need to look at what that CITAS is. You need to tell us what that CITAS is. And then rule number 3, when taking into consideration the patient's response to treatment, subsequent CITAS levels assigned must not be any greater than 2 levels below the pre-treatment. Like, it's really complicated. So the arrival CITAS, yes. So even if you treat a patient, your CITAS can't be greater than just 2 levels below. Yes. The arrival CITAS. So the arrival CITAS, remember, is the one that the patient at the hospital, yes, the scene CITAS, yes. So rule number 4 for patient, I don't know what BSA is, I'll have to check what that is. Patient who's resuscitated, I guess, the CITAS must stay as CITAS 1. So it's a patient who's probably gone through resuscitation, then the CITAS must stay at 1. And then rule number 5, paramedics receive termination of resuscitation order. When managing a patient, the CITAS level assigned for the patient and documented is the, I guess, based on the status of the patient on arrival and departure, if applicable. Yeah, so the last CITAS level. In cases where it is determined on arrival that the patient is obviously dead, then no CITAS level is required to be assigned and document that 0 is that patient. But I will just show you a glimpse of their document. Yeah, it's very interesting. So it's a whole field guide, and this is from the Canadian team. And I remember, as I mentioned, this then aligns effectively with the hospital. And these are the rules I was reading to you. And then the computer system. And then now, as you can see, organized approach CITAS determination in an adult. So you conduct a quick look, and based on that, you can assign CITAS level 1. There's some levels down there. If there's no obvious CITAS level 1, I'll just show you some of the criteria. Then you need to determine presenting complaint, and that can take the patient to CITAS 1. If there's nothing in CITAS 1 in the patient complaint, then there's a level of criteria that you need to go through, and then that then can either move the patient to CITAS 1, or then you need to categorize them. If there's none of that criteria, then to 1 to 5. Then if there's no obvious CITAS level 1, then second order modifiers and that. So I'll just show you what some of these modifiers. So this is highest level CITAS must be assigned of all applicable modifiers. So as you can see, group 1, respiratory distress, hemodynamic status, level of conscious temperature. Group 2 is pain score, bleeding disorder, mechanism of injury. So these are the first order modifiers. And then it goes into details. What are you can see first order modifiers, group 1, respiratory distress. So this is a whole classroom. As you can see, you get, if you have severe, and this is fatigue from excessive alcohol breathing, cyanosis, single word speech, all that starts less than 90, you're a CITAS 1. If moderate, that mild, moderate 3, none of this, then you're either 4 or 5. Then you go to the next level, you're looking at hemodynamic stability. Patients in shock get to CITAS 1. Patients who are normal end up down in 4 and 5. Remember, the third modifier in group 1 was level of consciousness. So 3 to 9, you get 1, 10 to 13, 2, others 3, 4, 5. And then temperature is also a modifier. So above 38.5 degrees, then you're looking at the immunocompromised, looking septic, looking unwell, looks unwell, then that. So it's a very nice tool from the perspective that it's very comprehensive. But of course, then you have to have the training, and everyone else must be understanding what you're talking about. I have some hospitals within Nairobi use sitters. So this using the pre-hospital would easily align with the hospital sitters level. So again, so this is what you're talking about. First order modifiers, group 2 is pain. As you can see, group 2 was bleeding disorder. And then group 2 was mechanism of injury. And that goes through that. And yeah, if you Google, you'll probably find some of this online and you'll be able to get this handbook, but we can probably also avail it as some of the resources available for this presentation. If you look at the second modifiers to be applied after the presenting complaint has been determined and the first have been applied. So there's a sequential thing. So you're looking at things like blood glucose, type 1 and type 2, hypotension, dehydration. But this is only being checked after you've gone through the first level. All right. Okay, so what's the take-home message? For me, it's very exciting. There's a lot of tools in the pre-hospital setting that we need to start looking at applying in our pre-hospital setting, and at developing pre-hospital tools that are evidence-based, and then co-creating pre-hospital tools with the facilities that you serve, so that you are able to have uniform communication in your triage and patient care, and ensuring seamless flow of patients from the pre-hospital setting to the hospital setting. We definitely need to move away from the just pick up the patient and dump them in the nearest facility. We need to move to now a more scientific way in which we are taking patients to the appropriate facility to ensure they have getting the appropriate care. So, and also then appropriately allocating resources based on how sick the patient is. Right. So for me, that's on this presentation. I'm really happy to take questions, and we can have some discussion even with the EMS people on the call. It would be good to also listen to some of your experiences. You can maybe type them out in the chat and I'll read them out. And just to see, is it something possible? Can we look at getting triage protocols done in our pre-hospital setting, and to allow for appropriate allocation of patients to the appropriate resources. All right, again, you can read this paper. From the conclusion of the paper, there was no real, well, I mean, the evidence is there's very few tools and very little evidence, but we need to start looking at it and developing. Dead on arrival qualify for priority 1? No. If you look at that CITAS, what they said is they do not, if you're dead on arrival at the hospital, then there is no, you don't get a CITAS criteria. Yes, but if you're on the scene, then you need to be resuscitated. Okay. Juma, thank you for a good presentation. Trauma triage tools mentioned prefer to use systolic blood pressure. Yes, when we know systolic blood pressure, the parameter tends to change late in trauma. Good question. Yes, and by the time your blood pressure is dropping, you're probably, as correctly mentioned by Rashid, is 30% of the blood has disappeared from your system. The capillary refill times were previously existing, but were removed because of the inaccuracies secondary to temperature variations. So they're not as accurate as your systolic blood pressure. And if you look at the systolic blood pressure, a lot of it in trauma settings, systolic blood pressure starts telling you, the moment it starts dropping, yes, you're definitely in a problem. And if it looks at perspective of, and that's what they're looking at. So a patient who has already dropped in their systolic blood pressure, then there's a problem with them. I just want to go back to quickly to look at it. So if you look at here, there is a systolic blood pressure, and this is varies. So a patient, of course, as you can see, Even the systolic blood pressure we're talking about is, as you can see, and heart rate is used. A heart rate, if your heart rate is higher than your systolic blood pressure, you're a red patient. So they are using the pulse rates to determine who is critically ill or red trauma patients. So yes, heart rate is normally a first indicator. It's normally a first indicator, but then they use other things, criteria. Yes. Thank you very much for the good compliments. Okay. Yes, notes, please share. The slides, I think the presentation will be there. I don't know, Lily, we are happy. I'm happy to share the link to the notes to this presentation. And you probably will get it in the comments or in the description of the video, either on YouTube or through Dr. Online. It's a useful discussion, and I encourage all of you, especially in the hospital setting, to dig deeper into the documentations that we'll share. And we are happy, as I said, through the foundation, we're looking to develop some pre-hospital tools. I think we're starting off with the dispatch center tools, then we'll move to the ambulance providers tools. So should be making this available as we go along. All right.